Good evening, friends. Welcome to all the members of Indian Arthroscopy Society. IES Academic Corner, it's a once in a month meeting. It would be held every second Saturday between 8 and 9.
Thank you, IPS. And also I thank all other EC members of IAS for agreeing this kind of platform, because it is going to help for both senior faculty as well as all the young surgeons to showcase their talent. I would like to welcome Dr. Miten, young and upcoming arthroscopic surgeon from Mumbai.
Thanks, and thanks for the nice, kind words. It's really my pleasure to moderate the inaugural session of IAS monthly meeting. Okay, now over to Miten, the upcoming budding arthroscopic surgeon of India. Miten, carry on.
It's a 34-year-old active athletic female with a skiing injury, non-contact 4 months prior to our consultation. The acute scans and management were done in the first 2 weeks, and she has been on and off rehab since then. Her predominant complaint is instability. She has less confidence in almost all pivot movements. She says that she can neither run confidently nor turn directions. On examination, she has a normal BMI, a neutral alignment, no hyperlaxity or hyperextension at the knee. The anterior draw is similar to the opposite knee. The Lockman is a grade 1 or 2. I could elicit a pivot shift, but just about. And no joint line tenderness, no varus valgus laxity, and full range of motion with no restriction. These are her MRI scans, where what I could understand was that there seems to be an injury to the ACL fibers. That doesn't seem to be like a mid-substance cut through or an avulsion of the femur or the tibia. There is very little bone marrow edema on the lateral femoral condyle or the lateral tibial plateau, and no evidence to suggest any anterolateral capsular injury as such, nor any injury to the MCL, LCL or the PLC. Now, the examination under anesthesia was that she had a firm endpoint to both her Lockman and her drawer, and the pivot shift again wasn't explosive. And under anesthesia, I could see that in extension, she had more of some translation, and in flexion, it was a little lesser. So again, on arthroscopy, a figure of 4, and you could see some peel off on the femoral side closer to where the PL bundle would actually be. It was, there was a significant translation in extension, more so, less in flexion. And because I could check, I didn't have the video with the probe really tugging at the fibers, but most of the fibers seem to be intact. So I happened to clean a bit of what seemed to be the posterolateral bundle femoral footprint, and I could see there was enough space there. I proceeded further to harvest a semitendinosus graft. And this is just a video that demonstrates the graft harvest. And we had to triplicate the semitendinosus, got a length of around 25. And on triplication, the femoral end was around 7 and the tibial end was 7.5. Meanwhile, on the arthroscopy front, I didn't actually get to measure the femoral footprint with a scale. But what I did was, when I used the reamers, I just tried to place the 6, 6.5 and 7 and tried to see if it was matching the footprint that I could see. This is a 4.5 reamer going on the bead pin, which was then followed by a 7 mm reamer on the femur. So here at this point, I put in the bead pin and then tried to check which reamer would be more appropriate. the 7 did at the end seem like probably maybe covering the entire footprint, unlike what I would have wanted, around 75 to 80%. And then on the tibia, we used a tip aiming guide and tried to find a point just behind the existing AM bundle. Just towards the end, when I wanted to get the reamer in, I had to pull the fibers of the AM bundle a little in the front with the probe, and didn't ream very aggressively. In fact, just pushed the reamer in, trying to protect as much of the native fibers as possible. And then we shuttled the sutures through. And we used an adjustable loop on the femur. Flip the button first and then shorten the loops to get the graft in. The graft was then cycled through a range of motion. It was very difficult to check if there was any impingement in deep flexion. The extension, of course, was free because the AM bundle wasn't touched at all. And we used interference through screw fixation on the tibia. There you can see the final picture, and I tried to tug at it just before this part, and you can see that there was hardly any translation then at the end of the construction. Partial ACL tests are probably seen by us in around 5, 10, maybe 15% of our cases. The clinical results of selective ACL augmentation, if we find an indication for them, are at par with standard ACL surgery. An intact PL bundle probably leads to a higher rate of a negative pivot shift. The diagnosis for us to lead to a treatment of selective ACL bundle reconstruction must consist of clinical exam, MRI, and examination under anesthesia, and a correlation of all these three. For the femur, Sonnery Cotte has spoken about trying to use an outside-in technique, because maybe if you use an accessory AM portal and drill, as we just showed, it leads to some loss of the native fibers. And there's a nice algorithm published which talks about how and when to offer an ACL augmentation for a selective bundle. So you look at the laxity compared to the opposite side. And if you have a knee that's not showing a lot of AP laxity and a negative pivot shift, then you'll end up try to conserve that patient. If you have a positive pivot shift in the absence of a significant draw or a lockman compared to the other side, and the patient is very young or has, of course, meniscal injuries and stuff, then you can offer surgical treatment. But other than extremely active professional athletes, most of those also would be conserved. And if you, of course, have an anterior drawer and a lockman that's significant or a great pivot shift and high risk, then that directly goes into surgery. For all the patients that are conserved, if after 2 or 3 months, if they persistently complain of instability, and then you have a case where you have a positive pivot shift and you may or may not have AP laxity, then you can correlate your MRI, your examination under anesthesia with this clinical reading, go inside, look at your ACL fibers and try to find if they are morphologically intact, look intact, and then probe them and tug at them to find out if they are functionally intact. And if you find anything intact, then you keep it there. And whatever is missing, you try and recreate only that. Thank you.
Yeah, this is a great concept to preserve as much native ACL bundle as possible. Did you mention anything about the keyboard's position, Miten?
So what's published talks about the keyboard's position, the figure of 4, giving us a better idea of the PL bundle. Also the fact that it stretches out in the figure of 4. So if there is a rupture, then that's the best position to try and look for some bleeding or some peel off. at the femoral end.
Okay, the only downside is sometimes trying to preserve the native ACL. Your tunnel may go a little non-anatomical, or in the end of it all, after making tunnels, you find that what you really wanted to preserve is torn. I don't know what the other's experience is. Any idea, Samantha? Sachin?
Yeah. I think doing the doing the PL bundle, sometimes there are too many issues are like that. You can overstuff. If your graph is more than 7 millimeter, then it is overstuffing is a question. And sometimes I completely agree with my arthroscopy guru, David Rajan sir, because he is the person who taught me how to hold the arthroscope in my beginning of my career. So whatever he is telling, like the figure of 4 position, and also the way we do the PL bundle, probably it is better to do the outside in technique. Who is for Sachin? What's your take on the outside in technique for the PL bundle?
I think outside in for me as well.
Yeah, Sachin?
So I think as regards isolated ligament reconstruction, ligament bundle reconstruction, I have gone away from them. There's not too much compelling evidence now that one should be doing, isolated AM or PL bundle reconstruction. One of the reasons being is that even if you do an isolated PL bundle reconstruction, your AM bundle has also sustained trauma. At the same time, it is more likely to have, the collagen is more likely to be injured. So in these patients in whom you see that, a lot of your ACL is intact, I prefer to do a standard ACL reconstruction, but I do a remnant preservation wherein I try and preserve maximum remnant as much as possible and try and take your graft through the remnant. But I would continue to put my tunnels at the anatomic position and do, standard ACL reconstruction with remnant preservation.
David sir, there one question to you, sir, as because you are the teacher for all of us. Thing is that, is there any recommendation how to put what is the ideal point for the PL bundle reconstruction? Any literature or your experience?
PL bundle.
PL bundle, isolated PL bundle.
Oh. No, you have to trace the torn PL bundle if possible, and I'm not sure what you are talking.
No. In literature, like people tell that it should be 6 millimeter below and 30 degree posterior to the AM bundle. Do we follow that, or we just take the surface fibers where it is torn and go ahead?
No, I would go whatever is torn and go that place, and retaining the AM bundle as intact as possible.
Sachin,
another probably you might be answering the other way, because I have seen people, whoever is doing the isolated PM bundle, they are doing the femoral tibial your entry at the middle of the footprint.
So if one wants to do a the classic PL bundle reconstruction, then you need to have a graft diameter which in the average Indian should not be more than 6 to 6.5 millimeters, which means that you end up taking either a 2-strand CEMETI or a 2-strand or a 3-strand gracilis, and you have to obey the correct tunnel positions, wherein you have to have your posterolateral, your PL tunnel on the tibia, which is more posterior towards the PCL and on the lateral flush with the lateral tibial spine, and then you have to come right in front of of your ACL footprint, and again tension it, not like how you would tension your AM bundle, but tension it differentially at about full extension.
Full extension, yeah.
Okay, my question is to Miten.
Yeah.
So, what is the patient? Did the patient have instability, and what made him to decide to do a PL bundle reconstruction in this case? How did he diagnose the PL bundle is there before the surgery? Only after arthroscopy, or what clinical finding, clinical compliance, or signs made him to do this PL bundle? Miten?
My clinical diagnosis before going in for surgery was that this patient likely has a partial tear compared to a complete tear. This was on the basis of, not the complaints per se, but the clinical examination that pointed more towards a lesser injury, because she had a very little pivot, almost no anterior drawer, and a grade 1-2 Lockman.
Did he have any rotatory instability clinically? I mean, when he complained about that rotatory instability?
So she said that she found it difficult to turn simple directions. I could probably take that as a marker for some rotational instability, but she couldn't run straight as well, which wasn't explained, because if she couldn't run straight means maybe she was having difficulty with controlling AP as well.
Yeah.
So the plan was to go in, have a look at the fibers, and probably go in for a conventional ACL reconstruction versus a remnant preservation versus something that I just did. What I saw under arthroscopy was that everything in the direction and region of the AM bundle seemed to be absolutely intact morphologically, though functionally there was some translation and you could see those fibers. There are two studies, one in 2016 by Bertrand Chonnery-Cotte and the other one in 2018, and I think again by Philippe Colombe and his group, that spoke about if you do a remnant preservation surgery in this case, or you keep what is morphologically intact, and you try and replace or reconstruct what doesn't exist, the functional outcomes, the return to sport, and everything is at par. There is no difference of proving one thing superior than the other.
Okay.
Miten, thing is that when you read this Chonnery-Cotte paper, probably from that we have all been referring to, they usually fix the tibia first and do the femur second.
Yes, sir. But why should that have a difference on the results?
No, because you did in different way, because you have used the tightrope on the one side and femur, and then you've done the tibia. So just for the sake of the question, because whatever they in their series they have done the tibia first and they have fixed the femur from outside in with interference screw. Is there any how you I think it's not going to change anyway.
I hope that it doesn't change in any way, because all that matters is that we get the footprints right and tension it. So I had one difficulty during the surgery where I didn't know whether the tip aiming guide on the tibia had to be taken from the side of the lateral meniscus or from the side of the medial meniscus. On the mediolateral front, if at all you're trying to reconstruct a posterolateral bundle, is it right in the center, more medial or lateral, and which way is it better? If I can get some guidance on that.
I think in that paper also they have not commented anything on the tibial side, because they are more or less concentrated on how to do the femur outside in and how to fix from the tibia femur from the outside in technique with the interference screw. As because probably you have done the correct way, because it is more or less middle. That's why some people are doing at the mid stump on the tibial side. And thing is that as because you have used the tightrope, probably you have one option still left. Even if you have done the tibial side fixes and still you can retighten on the femoral side.
I think it's aimed posterior to the tibial footprint and slightly in the lateral entry point where the posterolateral entry point should be there. I think Miten had showed that video also. The aimer has placed posterior to the normal footprint where that entry point was created.
Yeah. So nice one, Miten.
Thank you, Miten.
Thank you.
Good presentation.
Thank you for the opportunity.
Good.